Hello, friend. So, today we are going to discuss the next topic of the conjunctiva, that is vernal keratoconjunctivitis. And the short form of vernal keratoconjunctivitis is VKC. So, first we'll discuss about the overview and the pathogenesis of the VKC. So, VKC is basically known as the spring catarrh. First of all, the definition of the VKC. So, vernal keratoconjunctivitis, it is a recurrent, bilateral, and seasonal allergic inflammation of the conjunctiva. So, it is a seasonal allergy and it is bilateral and recurrent. And it is known as spring catarrh. Although the symptoms often persist throughout the summer, it is known as spring catarrh. Who is affected? Primarily, it affects the young boys in a ratio of 4:1 between the ages of 5 to 15 years, and it is more prevalent in hot, dry, and dusty climates. Next, the seasonal incidence trends. The chart illustrates the classical peak of symptoms that are during the late spring and early summer months, correlating with the changes in the temperature. So, mainly the peak is during the July season, starting from the May part. Next, the cellular pathogenesis. So, first of all, it is type 1 as well as type 4 hypersensitivity reaction. So, type 1 hypersensitivity reaction, there is an immediate IgE release reaction to the antigens. Type 4 hypersensitivity is a delayed T cell mediated response, and the key players in any cases of allergy, the key players are the mast cells, the IgE, and the eosinophils. So these are the main players which are present in any case of allergy. Histology shows the conjunctival thickness, which is increased, and hyaline degeneration. Next, the classification. So the classification depends upon the parts of the conjunctiva it involves. So if this is the eye, this is the cornea, this part of conjunctiva is the bulbar conjunctiva. The part which is present on the inner surface of the eyelids is the palpebral conjunctiva. So it involves the upper palpebral conjunctiva, which are characterized by the large papillae formation. Next, the bulbar conjunctiva. Bulbar involves the limbal area and features gelatinous thickening and tranta dots, which we'll see in the next slides, and mixed type, which shows features of both the palpebral and the bulbar forms simultaneously. As we can see in the palpebral form, this is the diagram which shows the palpebral form of the conjunctiva after everting the lid, which shows presence of large cobblestone papillae on the tarsal conjunctiva. So these are the papillae. They are very large, they are flat, and they are polygonal vegetations, and the surface may show milky white hue due to thickened epithelium and mucus. Next, in the bulbar form, which mainly involves the limbal area, shows the Horner Tranta dots. They are mainly characterized by gelatinous thickening of the limbus. The Horner Tranta dots are basically small white elevated dots at the level of limbus, and it basically composed of what? Eosinophils and the epithelial debris is included in these dots. They are commonly present in the superior limbus, and these are transient and indicate disease severity. So next we'll see how there's a formation of the ulcer due to this. So since we can see that on the palpebral conjunctiva, there is a presence of large papillae formation. These large papillae do what? They constantly rub They constantly rub on the cornea during eyelid movement, and due to that, it forms epithelial erosions, which forms epithelial erosions. These epithelial erosions heal completely with excellent visual outcomes, but in severe cases, what happens is these epithelial erosions are filled with mucus, calcium, and this prevents or this blocks epithelialization. And if there is no epithelialization, it will lead to shield ulcer formation, which is very important. Due to this waxing and waning, there are lipid deposits in the peripheral superficial stroma in an arcuate pattern, which is known as pseudogerontoxin. Pseudogerontoxin in stroma superiorly. So next we'll discuss about the various complications which we'll see due to this. So first it affects the cornea, and common complications first we have seen is the pseudogerontoxin, that is the lipid deposition in the stroma. Next we have shield ulcers which we have seen. Third is keratoconus. So how keratoconus happens? So due to constant itching, the patient has a habit of constantly rubbing his eyes, due to which there is development of keratoconus. So most important cause of keratoconus is vernal keratoconjunctivitis. Apart from that, it causes superficial scarring and it also forms micropannus. So pannus is basically infiltration with scarring, and vascularization. Next, there is a visual and refractive impairment, that is, VKC can call astigmatism, myopia, and hypermetropia. Due to lid complications or due to large cobblestone papillae appearance, it can lead to mechanical ptosis, and due to constant inflammation of the conjunctiva, it may lead to fibrosis and limbus stem cell deficiency in severe and untreated cases. Last is the treatment complications, because most of these patients are treated by systemic steroids or oral steroids or in the form of topical steroids. It leads to steroid induced glaucoma. Next, in differential diagnosis, first the vernal keratoconjunctivitis, atopic, and giant papillary conjunctivitis. These needs to be differentiated. Mainly the vernal keratoconjunctivitis patients are the children and the young teens, whereas atopic is the adult form of the vernal keratoconjunctivitis. The giant papillary conjunctivitis can occur in any patients, mainly the contact lens users. The seasonality mainly it occurs in the spring or summers, that is why it is known as spring catarrh, whereas atopic is perennial and there is no seasonal preponderance in giant papillary conjunctivitis. There is severe or intense itching in vernal keratoconjunctivitis, which can lead to keratoconus. There is moderate itching in atopic and mild itching in giant papillary conjunctivitis. The papillae size is very large or cobblestone in vernal. It is small or medium in atopic, and it is variable in giant papillary conjunctivitis. So this table needs to be remembered. Next, what are the management goals? So 90% there is resolution with the treatment. So first is avoidance, that is reducing exposure to heat and allergens. The second is pharmacotherapy, that is targeted relief of symptoms and inflammation. And third is education, informing parents about self-limiting nature of the disease, and it usually subsides after puberty. So there is a step ladder approach to this, but first the therapeutic options are journal options, which includes cold compresses, dark goggles, saline washes. Most important is the mast cell stabilizers, which is sodium coumabricate and olopatadine drops. Third is the topical steroids, which is fluoromethalon, immunomodulators like cyclosporin or tacrolimus, antihistaminics for acute relief of intense itching, and surgical treatment may be required in cases of shield ulcer, which includes scraping of the superficial ulcer or steroid injection in the supratarsal region. The ulcer, which is formed after scraping, can be covered with an amniotic membrane also to provide a scaffold for growth of the epithelium. So this is the stepladder treatment of VKC, which I was talking about. First, we'll start with the mast cell stabilizers and antihistaminics when there are no corneal changes. But when there is corneal vascularization and the papillae becomes macro, we'll start with topical corticosteroids. And when there is macro erosions, there is shield ulcer, which is very important, and persistent severe inflammation. It requires use of immunomodulatory agents, which are cyclosporin and tacrolimus. Thank you everyone for listening.